Hi, my name is Dr. Leela Landowski, and today we have Dr. Matt Reynolds, who's a consultant rheumatologist, and he's here to talk to us today about fibromyalgia. So Matt, can you tell us a little bit about what sort of patient cohort you might have for fibromyalgia in the clinic?
Ooh, good question. So very broad. So we would get anything from, usually I won't see children too much, that normally would come under pediatrics, but I'll see anything from teenagers up until right into the elderly with no problems. So we get referred fibromyalgia a lot. It often comes as a bit of a package deal with a couple of the other conditions we look after. So some people will just have pure fibromyalgia, and that's often a referral we'll get from GPs is, do you think this is just fibromyalgia, or do you think there's something else going on? And we'll try and split it apart, kind of wade through the waters and try and pick out from the story and from the examination and the investigations that we'll do, how much of this is disease, such as rheumatoid arthritis or osteoarthritis, and how much of this is fibromyalgia, which is pain hypersensitivity.
Can you tell us a little bit about the pathophysiology of fibromyalgia?
Good question. And I think if you ask me in about 30 years' time, I'll have a different answer for you. We don't know, to be perfectly honest. We know that it does involve pain hypersensitivity. Right down on the level of the neuron, there are changes there. We just don't know enough about them yet to be able to give well-targeted treatments.
So I'd just like to take a moment to explore the pathophysiology of fibromyalgia from a neuroscience perspective. Now, our knowledge on this area is very young. It's a very new area of research. So we've got a long way to go before we can really get to the heart of what actually is happening in the brain. Now, before I launch into this, just remember that pain is a subjective emotional experience. You can't measure the brain of two different people experiencing pain and say that one is worse than the other. We do not have the ability to do that at this point. But what we can see in people with fibromyalgia is that they have increased responses to stimuli or any kind of stimuli which may not necessarily always be painful to a person who doesn't have fibromyalgia. And here's an example of that. So what we have here is an fMRI brain scan of a patient with fibromyalgia and a healthy control. And what's happening in this situation is pressure is being placed on their thumbs, the same amount of pressure for both individuals. And the healthy control just perceives that as sensation, as pressure. And correspondingly, the different regions of the brain involved in sensation are activated. Now, on the other hand, in the fibromyalgia patient, they are having regions of the brain activated that are involved in the perception of pain and in response to painful stimuli. So this is actually telling us that they are perceiving this pressure, which a person without fibromyalgia would perceive as just pressure or some sort of sensation. They're experiencing that as pain. It is a very real sensation to them that it is a very painful stimuli. Now, we don't really know much about the mechanism that's driving this process, but there are certain receptors called toll-like 4 receptors, specifically on microglia, so the immune cells of the brain, that are implicated in this disease process. And as a result of that, people are starting to look at inhibitors or rather antagonists of these toll-like 4 receptors as potential therapeutics for fibromyalgia. So naltrexone, which is an antagonist of toll-like 4 receptors, has actually been shown in a number of studies at a super low dose to be helpful to some patients with fibromyalgia. And currently there are some clinical trials underway to better establish whether this is the case. So it's a very young area of neuroscience, and there's a lot we don't understand, but hopefully in the coming years we will have a better grasp of how to help people with fibromyalgia.
So a lot of the treatment we use at the moment is more, we know it works. We hope to find out in the future to be a bit more specific than that. That being said, the role of medicine in fibromyalgia isn't as high as perhaps other specialties, such as occupational therapy, psychology, physiotherapy, any of these specialties. And what we really try and do with patients with fibromyalgia, this pain hypersensitive, is try and demedicalize them. A lot of times I'll see people and they've been started down a pathway which involves a lot of medication. You'll see a raft of medications and you're sitting going, do you actually take all of this? And I say, yes, doctor, I do. It's like, oh, we need to get you off some of this. Is really what we'll try and do is deprescribe. Because realistically, if you've got a sheet full of medications, you're going to have side effects and drugs interacting with each other. And at that stage, the patient really often doesn't know what's helping and what's not. They'll sit there and you'll say, do you think that's helping? And they go, I don't know. So a lot of the time we'll start deprescribing and just sort of, let's do this together. Let's see what happens when we start this.
So you mentioned that there's obviously quite a big diverse team working with you. What's the utility of those other specialties working with you?
So really the evidence for fibromyalgia is in multidisciplinary team approach. Just seeing a doctor is going to get you nowhere. Basically, on a usual pain unit, you'll have physiotherapists, nursing staff, psychology, plus or minus psychiatry, and medicine. And initially, you'll usually get assessed by all three, either together or separately, and just talk about your story. And that's really where the goal is hearing people's story, finding out what makes them tick, and then trying to pick that apart as to how much of this sounds like it's an organic disease and what investigations can I do without over-investigating the patient. A lot of patients with fibromyalgia become very invested in their illness. They feel pain, they don't like having pain, they will Google search everything under the sun, and a lot of them come with preconceived ideas about what it is and what it isn't. And so we will really try and find out where they're at in terms of their willingness to engage in a multidisciplinary approach. Some people will straight away say, I know what's going on already, I don't need you, and that's fine. We probably won't have too much to offer. But if someone's willing to engage and sort of say, okay, I'm clearly not winning on my own, I need help, that's where the goal is. And so people who do have large histories of psychiatric illness, that'll play into their disease. And most people would say, most fibromyalgic patients would say, when my mood is bad, my pain is worse. And that's the main thing that people complain about is this pain hypersensitivity. They feel pain, even though there may not be a huge amount to find, which is why I said originally that it can come as sort of a package deal with other conditions, because you may have that condition, but you may also have fibromyalgia on top of it. So often it comes as its own entity, other times it comes as part of a package deal. But the ones who come as their own entity, it's quite rewarding if you can get them to a place where they're able to do the things they want to be able to do. And for a lot of the young people, that's work. People don't like to be stuck at home. You don't want to be watching TV all day. And often it's a snowball effect. People don't work, they stay at home, they put on weight, they don't eat well, they don't exercise. And you just watch this spiral of disease as people get worse and worse and worse and just can't find a way out of that hole. And that's often what a pain unit can help with. We'll be just finding ways that you can climb out of that hole. And often that's through things like exercise, been shown to be good for fibromyalgia. And we don't talk about running a marathon or going to the gym 7 days a week. It's small amounts of exercise, doing what you can do within the limits of your abilities. And really engaging often a partner to support them. And finding ways finding what makes them tick, finding things that they'll enjoy doing. Like, you can't tell a lot of people just go to the gym, they'll just say, I don't want to do it. It's very common to say, can you get into a pool? Do you enjoy swimming? And most people, without stereotyping too far here, a lot of us are overweight. And so people may feel very self-conscious about getting into a pool. I know, right? Sensitive topic. Anyway, but a lot of people don't like to talk about it. It's a sensitive topic, but people know that they need to lose weight. And asking these people, do you want to get into a pool? They'll often say, no, I don't want to get into a pool. So, okay, what else can we do instead? Do you like walking your dog? Great, there's something we can do. Let's do that more often. And just finding ways that you can approach them to exercise more, sleep better, and whether or not we try some medications, we often don't like to bomb people out to make them sleep. We prefer them to sleep well on their own. And a lot of this then comes down to, can I teach you basic sleep hygiene? Things like getting off your phone while you're in bed, not watching TV in bed, making sure the dog's not keeping you awake overnight, you don't have a cat jumping on your face at 3 a.m. Just basic things like that, which can help people sleep better and feel more refreshed. You give your brain that time to relax and just process what's happened over the day and just process where your body is and say, okay, how much disease is actually here? Do I actually have sore joints? And just having that better night's sleep can make people feel so much better. And that's things that you might look at in these in a pain unit and do a lot of group activities where you can relate to other people and realise you're not alone. So we'll often engage a pain unit for people with fibromyalgia once we're sure that there isn't something organic going on as well, and often get that under control. Then a pain unit can help to deal with the rest.
Are there any other psychosocial aspects that we need to consider with a patient with fibromyalgia?
Things like stress. Stress and psychology, very, very important. So that's why when people, say for example, bad times at work, we'll often find ways to either manage their work better. And so a lot of that is finding a receptive work where they can work limited hours, for example, not making people work 12-hour days or night shifts and things like that. And it's obviously easier said than done to just say, go find a job where your boss will say, don't worry, I only work 4 hours a day. But if we can find work like that, I remember I had a patient a couple of years ago who worked in a cafe and she wanted to fall pregnant. And so she was desperate to get off this truckload of drugs that she was on. She did so well, like she was working and just slowly reducing, and happy result in the end. And it's those sorts of stories where you just go, yes, we know you can get better. That makes it worthwhile doing and making an effort. Fibromyalgia is very easy to say, it's all in your head. And 20 years ago, that's what patients would have been told, this is all in your head. But these days, we know that so much of people's pain experience can be modified. You can get people feeling better, and it's not something you can do on your own. So definitely involve as many people as you can, knowing that it is a finite resource. The pain unit in most places only can support X number of people, so not sending absolutely everybody to them, but people who you know were wanting to engage in that sort of a paradigm.
Fantastic. Matt, thank you so much for your time talking about fibromyalgia today.
Welcome, thanks very much for having me.